mismatch today, last topic on RS equations. So we have talked about all this last week. So we're going to talk about shunt and VQ mismatch concept today. So before going into the topic, just quick revisit on our blood circulation. Divided into systemic and pulmonary circulation. So what I wanted to highlight here is regarding arterial system and venous system. Bear in mind, arterial system means blood is flowing from the heart to an organ. Okay, so it is aorta. So the blood from the left side of the heart is pumping towards from the left ventricle going to the aorta and going to all the organs. And pulmonary artery. Okay, it's from the right heart, from the right ventricle, goes through the pulmonary artery to another organ, which is lungs. So this is arterial system. Arterial system is flow of the blood from the heart to an organ or another organs. Whereas venous system is flow from organ back to the heart. So we have our vena cava, pushing back all our systemic circulation, venous return into the heart, right side of the heart. And we have a pulmonary vein, which is push our pulmonary circulation back from lung into the left side of the heart. It is not on the blood oxygen level. Arterial or venous is not based on your oxygenated status of your vessel. Not as in oxygenated blood will be in artery, deoxygenated blood in the vein. So if you have to understand the concept, otherwise you will get confused here, because pulmonary artery brings deoxygenated blood from the right side of the heart to the lungs to get oxygenated. And vein brings back the oxygenated blood from the lungs into the right side of the heart to go into the systemic circulation. So whether it's arterial or venous, it's all from the blood. Either it's going out of the heart or going towards the heart. So this is the concept you have to understand before we go into today's topic, talking about shunt and everything. So the core recipe today is V and Q, ventilation versus perfusion in your lungs. So in a normal lung, which has a ideal ventilation versus perfusion, you will get a VQ ratio of 0.8. The perfect one is 1, but we won't get a VQ ratio of 1 because the perfusion is always more than your ventilation. If your ventilation is around 4 liter, your perfusion will be 5 liter. That's why you get VQ ratio of 0.8, which is normal. In ideal situation, 100% normal alveoli, which has all are open and functioning, then when you get in 1, which is not physiologically normal. Okay, so now that's a normal alveoli. So then we have a dead space ventilation where a alveoli is being ventilated, okay, but it's not being perfused. There is no blood perfusion. So that is dead space ventilation. So V is 1 full, Q is 0. So it's infinity. Anything divided by 0 is infinity. Then we go to shunt equation where B over Q is 0, where there is perfusion, but there is no ventilation. There is a obstruction to the ventilation to the left. So the alveoli is not being ventilated, only being perfused. So the extreme, so dead space is the extreme degree of VQ mismatch where there is no perfusion, whereas shunt is the extreme degree of VQ mismatch when there is no ventilation. So dead space and shunt actually is a part of VQ mismatch, okay? But we put shunt as a separate cause in hypoxemia. The day we talked about 5 causes of hypoxemia: low FiO2 or low partial pressure in oxygen, alveolar hypoventilation, we talk about diffusion abnormality, then we talk about VQ mismatch, and then we put shunt as separate. Even though now I'm saying shunt is a part of VQ mismatch, because shunt, there are 2 types of shunt, physiological and pathological shunt. We'll come to the concept later. That is why shunt has been classified as a separate cause of hypoxemia, is not included as a VQ mismatch itself. So we come to the shunt equation that we're going to talk about. What are the factors that involved in shunt equation? What is the importance of this shunt equation and the concept of shunt fraction? How do we derive to it? And what is the implication of this shunt equation? So we have an alveoli here. So ventilation, the air is coming through, inspired air will come into the alveoli. You have a pulmonary artery which brings deoxygenated blood from the right side of the heart, from the right ventricle coming here, which then the blood that goes through will leave the alveoli, leave the pulmonary circulation after being oxygenated from alveolus towards the to the left side of the heart during using pulmonary vein. So the whole cardiac output from the right side of the heart will go through pulmonary artery into pulmonary circulation, into the pulmonary capillaries, and the whole cardiac output supposed to leave the pulmonary circulation via the pulmonary vein into the left side of the heart. Okay, this is the total flow of cardiac output, both sides. So if, don't look at this part here, if there is no shunt, the pulmonary artery will receive the full cardiac output from the right side of the heart, goes through the pulmonary circulation, and without any abnormalities, this whole cardiac output should return back to the left side of the heart via the pulmonary vein. Okay. So this pulmonary artery will contain venous oxygen. Okay, venous oxygen as in, sorry, deoxygenated blood. So which is a mixed venous blood. Okay, we call it mixed venous blood here because it's carrying a systemic circulation venous return. Whereas once it reaches the pulmonary vein, it contains the arterial oxygen content. CaO2 is the arterial oxygen content. CbO2 is the venous oxygen content. Okay, then we have our pulmonary capillary. So pulmonary capillary, from pulmonary artery, it goes through pulmonary capillaries and exit via pulmonary vein. So if the whole of the blood is going through pulmonary artery, going through pulmonary capillary and pulmonary vein without shunt, all this blood will get ventilated and perfused. So at end capillary blood at here, this blood will equate the PaO2 and PCO2 from here. Okay, this is the oxygen. CCO2 is oxygen content at end pulmonary capillary. Okay, CCO2, CbO2 and CaO2. Whereas if there is a shunt, anatomical shunt, the blood will bypass. Some of the blood will take another route to reach the pulmonary vein via the shunt where it is perfused. This part perfusion is there, but there is no ventilation at all. So this blood, this mixed venous blood from here will pass through the shunt without undergoing any gas exchange and will mix with the oxygenated blood from the pulmonary capillary, thus reducing the oxygen content, final oxygen content. That's why shunt is important, because shunt reduces the final oxygen content of the pulmonary vein before it reaches the left heart. So we'll talk about it again. So this flow that bypassing the pulmonary capillary and reaching the pulmonary vein is called the shunt flow. So the flow of shunt, a percentage of the flow of cardiac output that going through shunt is the shunt fraction. The QT is the total, which is the cardiac output. The part of the cardiac output that going through the shunt is the shunt flow. So that will be your shunt fraction. We'll talk about it again. So how do we find out the CCO2? We will use the concept of QT minus QS, because total cardiac output is QT, shunt flow is QS. So we will discuss how we derive to all this in a while. We talked about oxygen cascade 2 weeks ago. The part that I want you all to highlight now is this part. From alveolar gas to arterial blood, there is drop of PaO2 from 150 to 100. From inspired gas 150 to alveolar gas 100 PaO2 millimeter mercury to arterial blood of 95. It can go up to 80 also, as I mentioned last week. Hypoxemia is classified as mild below 80 millimeter mercury. The reason there is a drop from PaO2 in alveoli to the PaO2 in arterial is because of this VQ mismatch or concept of venous admixture and shunt. So VQ mismatch and shunt are the reason why there is a drop of oxygen level from alveolar to arterial. So it is VQ mismatch. There is a concept of venous admixture, and we come to a QSQT is the shunt. Okay. So we know alveoli PO2 is 104. It can drop up to 100 to PO millimeter. It can drop up to even to 80 millimeter mercury. Depends on the level of VQ mismatch, level of venous admixture, and shunt. A quick recap from the last class for those who never attend. We talked about shunt and dead space. Shunt means there is the alveoli is not being ventilated, but there is perfusion, whereas dead space is the alveoli being ventilated, but there is no perfusion. Then we talk about hypoxemia versus hypoxia. Hypoxemia has low partial pressure oxygen in the blood, so just low PaO2, whereas hypoxia has low oxygen supply at tissue and cells. Okay, hypoxemia is because of low oxygen intake, defective oxygen exchange at alveoli. It involves external and internal respiration, whereas hypoxia is defect in cellular respiration, where it can be a defect in delivery or defect in oxygen utilization. It does not always coexist. One can present in absence of another condition as well. The causes of hypoxemia: 5, hypoventilation, low FiO2, VQ mismatch, shunting, and diffusion abnormality. We went to a concept of AA gradient, which is AA means partial pressure of alveolar oxygen minus partial pressure of arterial oxygen. PaO2 we get from alveolar gas equation, and partial pressure arterial oxygen we get from your ABG. Normal value is 5 to 15. We can give a value up to less than 20 is considered normal, because partial pressure of alveolar oxygen in ideal situation is 100 millimeter mercury, and I said mild hypoxemia is classified as 80 millimeter mercury and below. So 100 minus 80 is 20. So up to 20 millimeter mercury of AA gradient is acceptable. Any widening AA gradient will show there is certain degree of hypoxemia. So the simple calculation for expected AA gradient for H will be H divided by 4 plus 4. This is bedside calculation. Then we use the concept of AA gradient to identify the causes of hypoxemia. If the AA gradient is normal, it could be hypoventilation, low FiO2, or VQ mismatch. Hypoventilation or low FiO2. If the AA gradient is widened, it could be VQ mismatch, diffusion limitation, or shunt. How do we, if it's normal, how do we know whether it's hypo or hypoventilation, low FiO2? We look at the PCO2. In hypoventilation, PCO2 will be high. In low FiO2 or low PiO2, the normal PCO2. Then looking at normal, we can identify these two. But for widened gradient, how do we know which one is which? We do the 100% oxygen challenge. 100% oxygen challenge, of course, in a normal AA gradient, it will improve. In a widened AA gradient, it will respond very well in VQ mismatch, and it will respond very well in diffusion limitation. Whereas in a patient with shunt, it won't not respond much. There won't be any reduction in the AA gradient much. So the shunt will cause less response to 100% oxygen in a patient with hypoxia if shunt is the cause. So some of you texted and asked me, how do we actually, okay, we have talked about this. We can actually distinguish either hypo or low FiO2 based on PCO2. For widened gradient, we have shunt, diffusion limitation, VQ mismatch. Shunt versus these two, we can know whether the 100% oxygen. But how do we differentiate VQ mismatch and diffusion limitation? So that is the concept of DLCO comes in. That is the reason I shared short notes on DLCO. If you all paid attention to the group and studied about it. So DLCO come into the picture for us to know whether it's actually a diffusion limitation or not. So we give 100% oxygen. If it's a normal A gradient, we go into this pathway. I'm not going to talk about it. So if it's a widened A gradient, give oxygen. If doesn't improve, it's shunt. If does improve, it could be VQ mismatch or diffusion impairment. So that's why we check DLCO. If the DLCO is normal, then it's most likely VQ mismatch. If DLCO is reduced, DLCO is the diffusion capacity of lung for carbon monoxide. Okay, so if that is reduced, that will be a problem with the diffusion, means the alveolar capillary membrane have diffusion impairment. So that is the concept of DLCO. And then we talked about different types of hypoxia: hypoxemic, circulatory, anemic, and histotoxic last week. So we're not going to delve into it again. So now we come to the concept of shunt versus VQ mismatch. Shunt is a type of VQ mismatch. This is a repetitive slide. Again, shunt is the extreme degree of VQ mismatch when there is no ventilation. But shunt itself can be a separate cause of hypoxemia if it's an anatomical shunt. It does not go through pulmonary circulation at all. Shunt can present in pulmonary, shunt can present in cardiac circulation. Okay, the shunt can be a problem of VQ mismatch if the shunt is present within the pulmonary circulation. It means the blood is passing through pulmonary circulation. It passed through alveoli that are not being ventilated or being partially ventilated, partially opened up. So that is pulmonary shunt. But shunt can also occur outside your pulmonary circulation in cardiac, where you have a ASD or VSD. We can get a right to left shunt where there is a direct mixing of deoxygenated blood from the right side of the heart into the left side of the heart and into the systemic blood circulation, bypassing the pulmonary circulation. And there is some physiological shunt that also does not involve your pulmonary circulation, as I mentioned, your venous drainage of your cardia and your pulmonary, which is your bronchial circulation and your Tibial veins. So we'll come into it shortly. So this is again the concept. So this is the normal alveoli. Okay, this is the pulmonary artery bringing a blood from the right side of the heart, goes through a well-ventilated alveolar unit, goes back to the pulmonary vein. Then we have pulmonary artery, blood that passes through alveoli that are partially ventilated. So this is VQ mismatch. Either there is purely perfused or poorly ventilated alveolar units. Okay, so that will cause the VQ mismatch. But there is another pathway that it takes through which does not involve any alveoli. So it does not pass through any pulmonary gas exchange area. So that is called anatomical shunt. That is pure bypass of the pulmonary circulation, which we call as an anatomical shunt. So from pulmonary artery, it directly reaches your pulmonary vein. So that is the anatomical shunt. Pure shunt we talk about. So again, the concept of VQ mismatch versus shunt. In VQ mismatch, we can see the perfusion is somewhat maintained. But the problem is with the different degree of ventilation. A properly ventilated alveoli, a partially ventilated alveoli, and a collapsed alveoli. Whereas in shunt physiology, the problem is the ventilation is not at all there. There is perfusion, continuous perfusion, but there is no ventilation at all, zero. It is totally bypassing the gas exchange part. This is an ideal alveoli passing through. So we know our inspired PiO2 is 150 millimeter mercury. We have gone through the measurements and everything. And we always assume your atmospheric pressure, because your CO2 content in your atmosphere is very, very low, we take it as 0. So when at the alveoli, we know our alveoli get, by the alveolar gas equation, we get a 100 to 102 millimeter mercury. And the PaCO2 in alveoli is 40 because it equilibrates with your venous blood very fast because of high solubility of your CO2. And PiCO2 earlier is 0 and PbO2 is 40. The gradient is high. So the venous oxygen, venous CO2 will equilibrate with your alveolar CO2 very fast because of the high solubility as well. So eventually, this will end up in this equilibrium of O2 lower than 40, yes, 102. The O2 will go out from alveoli into your vein, increasing the oxygenation, and PCO2 from 46 to 40 will go in here. At the end, after the full gas exchange and perfusion, you will get a PaO2 of 100 and PCO2 of 40 before venous admixture happen. This is ideal if there is no shunt, if there is no venous admixture. So your PaO2 will equalize your arterial O2 at the pulmonary vein. Okay, so it will equalize whatever is there. But this does not happen in a real life. So this is ideal where VQ is 1. Okay, 1 to 1. Whatever is here, perfectly we get back. Here we look at alveoli being hypoventilated, less ventilation, okay, reduced ventilation. So when you have a reduced ventilation, the VQ is less than 1. Your ventilation, your perfusion is normal, but your ventilation is reduced. V is lesser, Q is still higher. So what you get, VQ of less than 1. Thus, the end capillary, okay, at the before reaching the pulmonary vein, the end product, you can see there is a drop in PO2 level. But the PCO2 is still somewhat maintained, not much different, because your PCO2 has a very high trigger for your chemoreceptors that can increases your alveolar ventilation to match up your PCO2 level. Okay, it equilibrates or it compensates faster your CO2. Okay, next we look at an alveoli with totally no ventilation. There's obstruction. This is called ventilation where zero ventilation. Okay, there's total obstruction. So this alveoli is totally not being ventilated. Okay, so thus the oxygen from outside cannot reach the alveoli. There's alveoli, thus PaO2 will only equilibrate with whatever that comes from your venous. Okay, your venous oxygen is 28, it will equilibrate with that. Your PaO2 will be 28. The PCO2 will be 46, it will equilibrate with 46. That it will drop after the multiple alveoli, thus the last PaO2 will be even lower. Then we look at a condition when there is a shunt. When there is a pure anatomical shunt, right to left shunt, you see this pure anatomical left shunt, the total mixed venous blood, it's 100% gonna join back here, thus reducing the PaO2 is even lesser. Even though the PaO2, the alveolar O2 is 102 millimeter mercury here, because of the venous admixture via this right to left shunt, which is outside the pulmonary circulation, it drops your PaO2 much higher compared to in other situation. So this is how the difference from VQ mismatch to dead space ventilation, VQ mismatch to pure shunt, and also the reduced ventilation, alveolar hypoventilation situation. So what that brings us to a concept of venous admixture, because there is some confusion regarding the word venous admixture and shunt. Shunt is actually a part of venous admixture. So what does venous admixture mean? It's a mixing of non-reoxygenated, not D, not DE, is RE. Non-reoxygenated blood. It means blood that goes to pulmonary circulation, it's not being oxygenated, non-reoxygenated blood. Okay, blood that has no or incomplete gas exchange mixing with reoxygenated blood. The blood that does not pass through pulmonary circulation for gas exchange, mixing back that blood that has went through pulmonary circulation to get oxygenated. That is venous admixture. Where that is happened, it at the end pulmonary capillary. It occurs at this level. Okay, at the end pulmonary capillary. If we look at this picture, it look at this area. So end pulmonary capillary. Okay, this is a mixture area. So that is venous admixture. So where does this, so what does it do? It causes drop in end capillary PO2, thus reducing the PaO2 and CaO2, arterial content, and PaO2 partial pressure oxygen and arterial oxygen content, that reaching the left heart. Thus, the blood leaving the left heart via aorta into the systemic circulation also will have a lower partial pressure of oxygen. Where does this non-reoxygenated blood comes from? It can comes from physiological shunt, which is shunt that occurs in all of us. It is physiological. It is there. It is not a mixed venous blood. Okay, it is not mixed from the systemic circulation. It comes directly from the bronchial circulation and Tibetan vein. Okay, they are very minute, but this is the reason why don't we get a ideal VQ as well, because there is some amount of shunt, and this is the actual reason why there is a drop of PaO2 from 100 to 95, a drop of 5 millimeter mercury in a person who are healthy and young with no pathology. Okay, even though the lungs are okay, the person is well, why there is still a drop of 5 millimeter mercury, 5 to 10 millimeter mercury of PaO2 from alveoli to artery? Because of this. Okay, this is present physiologically. Okay, whereas pathological shunt are also called anatomical shunt. The reason why I highlighted in blue, pay attention to this. Anatomical shunt, to be precise, it's only talk about 100% non-ventilated, like this. 100% non-ventilated. These are anatomical. Okay, that is anatomical plus cardiac shunt. These are all non-pulmonary related. They are nothing, they are not coming in contact with 100% with alveoli. That are pure anatomical shunt. But pathological shunt also involve the perfusion, the pulmonary capillary that pass through partially ventilated alveoli, like this. Collapsed alveoli. Okay, that also can be pathological, but they are not anatomical. All these are pathological, but when I say anatomical shunt, anatomical means that are out of pulmonary. That means they are not coming in contact at all with alveoli. That is non-ventilated alveoli or cardiac shunt, right to left shunt. In a non-ventilated alveoli, the VQ will be 0. In a less ventilated alveoli, the VQ will be less than 1. Okay, so that is the pathology. Cardiac shunt does not causes VQ mismatch. They causes straight direct drop in PaO2. Okay, they are not talking VQ mismatch. We are talking about ventilation and perfusion in the lungs. So this is the ideology of what is the concept of venous admixture. So shunt is actually a part of venous admixture, but venous admixture consists of two shunt. When we talk about the shunt in hypoxemia, we are talking about this shunt, pathological shunt. We are not talking about physiological shunt. Physiological shunt is acceptable. So when you have a well-ventilated alveoli, when you have a purely ventilated alveoli, and we have an anatomical shunt. Well-ventilated alveoli, of course, contain a high oxygen content. A partially ventilated will have a reduced degree of oxygen. Anatomical shunt will not have any increased oxygen content. Thus, they all contribute to the final oxygen content in the artery, which is the pulmonary vein, arterial system that goes back to your left side of the heart. So, as I mentioned, the venous blood mixes with the fully oxygenated blood and reduces the saturation. Okay, so we can see the content of the fully oxygenated blood versus content of the mixed venous blood. When they mix together, they will drop the final oxygen content from 130. Because of the mixture with the 97.5, it become 117. So shunt actually reduces the partial pressure of oxygen at the end, and thus also reduces the arterial content of the oxygen that going back to the left heart. All these bring us to the shunt equation. Again, we have all these things. So shunt equation is shunt flow over total flow is equivalent to oxygen content at the end pulmonary capillary minus oxygen content at the arterial O2, which is your pulmonary vein, CaO2, divided by pulmonary capillary oxygen content minus venous oxygen content. Okay, shunt fraction. QS over QT is the shunt fraction. We have all this information here. So how do we going to QT? QT is the blood flow, the total cardiac output that comes from your right heart and leaving to the left heart. Shunt flow is the flow that goes through shunt without bypassing any alveoli. Where do we look for the end capillary oxygen? We will measure the capillary oxygen at the end of the pulmonary capillary. CaO2 we will measure from the pulmonary artery, pulmonary vein, or we can directly use the ABG and everything. So the oxygen content equation, we'll talk about it. So these are the shunt equation. Repetition, blood flowing through the shunt, total cardiac output, pulmonary end capillary oxygen content, arterial oxygen content, pulmonary end capillary oxygen content, and venous oxygen content. This QS or QT brings us to the concept of shunt fraction. What is it? Percentage of cardiac output flowing through the shunt. So how do we derive to this equation? So the reason how do we come into the equation is, we know the total oxygen uptake means total oxygen that being uptake from the alveoli into the pulmonary circulation or picked up from the alveoli or delivered from the alveoli into the blood vessel. Why do I use all these different words? Is different books mention different word. So just for it's total oxygen uptake from the lung, or total oxygen picked up from the lung, or total oxygen being delivered from the lung into the blood, all are same. Okay, ideally leaving the blood pulmonary flow is equivalent to blood flowing through the ventilated area, this blood capillary, pulmonary capillary, plus blood flow through non-ventilated area shunt. So the total oxygen uptake is whatever oxygen that present here plus oxygen that present in the shunt flow as well. That will be your final oxygen content. Okay, that is being picked up. So how do we calculate? So we know oxygen delivery or flux. So this delivery is equivalent to flow time oxygen content. Flow is your cardiac output. Oxygen content, we have talked about the oxygen content equation previously. So total oxygen delivered. What are the oxygen that being delivered here is QT. Okay. So whatever that oxygen being delivered to the system is this final. Okay. Delivered mean delivered to the systemic circulation, delivered to the left side of the heart. The oxygen delivery is towards the left side of the heart and systemic circulation. So you talk about QT times CaO2, this part. This is total oxygen delivered. Okay, total oxygen delivered is QT times CaO2. Blood that flow through your shunt is QS times CbO2, because the CbO2 blood, the blood from your venous, from your pulmonary artery, which contain a mixed venous blood, either takes a by pulmonary capillary route or shunt route. So when it passes through the shunt route, you take the shunt flow. How much is the shunt flow times your CbO2? And blood that pass through the pulmonary capillary, the oxygen content will be there. QT, the total minus the shunt flow, the total flow minus the shunt flow, times with the end capillary oxygen, the oxygen content here. That will be the oxygen delivered. So this is the total oxygen uptake. So how do we going to calculate? So that brings us to
this equation brings us to QT times CaO2 equivalent to QS times CbO2, blood flowing through shunt, plus blood flowing through a ventilated area. So this is this equation. So how do we go from this equation to get this shunt fraction equation? Back to this. Back to this equation. Total oxygen delivery equivalent to shunt delivery oxygen plus your blood flowing through your pulmonary capillary. Please forget this plus sign. Ignore this plus sign. So we will put it as the multiply. I just put it as a dot. QT times CaO2 times equivalent to QS times CbO2 plus you open this up QT CCO2 minus QS CCO2. Then you bring all the QT to one side. So QT CaO2 minus QT CCO2. From plus here, we bring it back to the other side, it become minus, equivalent to QS CbO2 minus QS CCO2. Then you take out the QT outside and QS outside. You get this equation, QT equivalent to CaO2 minus CCO2, QS CbO2 minus CCO2. You rearrange this. You bring this because we want to get here QT over QS, but we want QS over QT, right? So we will just switch it back. When you switch it back, the negative and positive will become changed. So the CC will be positive, CV will be negative. So we go to the other side. So the CC minus CbO2, CCO2 minus CaO2. Whatever that is positive on this side, when go this side, become negative, right? Simple mathematics. Whatever positive on this side, when go this side, will become negative. So that's how we got it. So we rearrange it. QS over QT, CCO2 minus CaO2 divided by CCO2 minus CaO2. Okay. This is how we got our calculation. Okay. I'm sorry, there is a small typo here. This is CaO2 over CbO2. Pardon me for this typo. This is the final equation. CCO2, N capillary oxygen content minus arterial oxygen content divided by N capillary oxygen content minus venous oxygen content. Okay, there is a typo here. Please pardon. CaO2, CvO2. Okay, there's a difference here. Please take note of this mistake. So again, we come back to this. So we have this equation now. We have already derived this equation. So how do we gonna calculate the shunt fraction now? So the task is to find the QS. We will know our QT because that equates our cardiac output. QT is cardiac output. But we have to find what is the shunt here. So once we have the shunt value, we can put it over QS over QT and we get shunt fraction. So info that we needed is QT. QT we know cardiac output. Then we have to know CaO2. Okay, arterial oxygen content, venous oxygen content, and capillary oxygen content. And we have already learned last week how do we calculate oxygen content is calculating arterial HB bound oxygen, plasma oxygen dissolved. Okay, the oxygen that is bound to your HB and oxygen that is your dissolved in plasma. So your CaO2, this will be your equation. CbO2, this will be your equation. This is for your HB bound oxygen. This is your dissolved oxygen. Okay. And then for CCO2, for arterial oxygen content and venous oxygen content, you can take ABG or VBG to get PaO2 or PvO2. Okay. But how do we gonna calculate the CCO2, capillary? How do we gonna get this partial pressure of capillary oxygen? Because the pulmonary capillaries are direct contact with the alveoli and it will be equilibrate with the oxygen in the alveoli. We will take the partial pressure of alveolar oxygen as the partial pressure oxygen at the end capillary to use in this equation. So how do we get this PaO2? We will use alveolar gas equation. We talked about it. In alveolar gas equation, how do we, once we get a PaO2, we use the alveolar gas, we use the PaO2 and to get SCO2 because we need to get saturation. Saturation of arterial, you can get it from your ABG. Saturation of venous, you can see your ABG as well. It will come out there. But how do we go and get the saturation of capillary to be used in the equation? We use oxygen dissociation curve. Once you get your PaO2, you put your PaO2 value and look at your curve, you will get your SCO2 using your oxygen dissociation curve. In ideal alveoli, which is all the alveoli being ventilated without any VQ mismatch, your ideal PaO2 is 100 millimeter mercury. And we know at ODC of 100 millimeter mercury, we get ideal saturation of 100% or 99.75%. So what is this? Is your alveolar gas equation. So this is the information that needed. How do we put it in and get back? So again, looking at it, if you get a PaO2, let's say your alveolar gas equation you did and you get 100, then you get the SCO2, saturation of capillary oxygen 100. Let's say if that patient has some pathology and you calculate your alveolar gas equation to be only 80 millimeter mercury. Your PaO2 is reduced, P alveolar O2 is reduced. Then again you look at 80 millimeter mercury, we can get saturation of 95 around that. Because we know the oxygen dissociation curve does not drop drastically unless your PaO2 drop below 60 millimeter mercury. So at the higher partial pressure of alveolar oxygen level, your hemoglobins are still highly saturated. So that is how we come. So this is just repetition of your how do we calculate the oxygen function. Oxygen content are calculated by calculating oxygen bound to hemoglobin plus oxygen dissolved in blood. Your hemoglobin times your Afner's constant 1.34 times your saturation in decimal plus your dissolved PaO2 with solubility of oxygen 0.003 mil per millimeter mercury. Either you use PaO2 or PvO2, venous partial pressure oxygen or arterial partial pressure oxygen, saturation of arterial oxygen and saturation of venous oxygen. Okay, that all we can get from our blood gas analysis. What we wanted to find out here is by using alveolar gas equation to get PaO2 to use in this capillary oxygen content equation and the saturation of capillary oxygen here. Hope this is clear. So why this is important to find about this shunt fraction? Why this is important to find about this shunt fraction? Because shunt fraction will tell you about the PaO2. Okay, it is the PaO2 will directly related to your shunt fraction. The lower the PaO2, the higher the shunt fraction. Let's say you have your ABG, PaO2 of only 60 millimeter mercury, and you are suspecting this patient have a pathology of shunt being the hypoxemia. Then we can calculate, then it can correlate with your shunt fraction. Because if you can look at it at the PaO2 of 60 millimeter mercury, our SpO2 will be only around 75%. And the PaO2 result in shunt fraction. And that is the concept of PF ratio comes in. Okay. Your PF ratio that we use in your ARDS, it is also a rough estimate of your shunt fraction. When you use your PaO2 or FiO2, if less than 200, means patient already in moderate ARDS, your ARDS classified mild, moderate, severe. PF ratio less than 300 is mild, less than 200 is moderate, less than 100 is severe. If less than 200, the shunt fraction is thought to be more than 20%. If the shunt fraction is more than 200, the shunt fraction is said to be less than 20%. You don't have to know this in detail, this graph. This is just for explanation to show how does the drop in PaO2, how does the shunt fraction related to drop in PaO2. Okay, so this is how we derive for shunt equation. You have to know how do we derive to this shunt equation following all this, and what is the implication of the shunt fraction is this shunt fraction will cause us drop in PaO2 equally by using this graph. Next, we come to the concept of VQ mismatch. We have already talked about VQ mismatch involve shunt and also dead space ventilation, where shunt is the extreme, shunt and dead space can be the extreme degree of VQ mismatch. But what we talked about, what we're going to talk about in VQ mismatch here is what are the values in between these two. We are not talking about the extreme where shunt and dead space. We are talking what is in between. And among the 5 causes of hypoxemia, bear in mind, VQ mismatch is the most common cause of hypoxemia. Many conditions that we see in ICU, patient admitted with pneumonia, patient with APO, a lot of other problem, everything mostly related to your VQ mismatch. So what is VQ mismatch? We talked about ideally ventilated lung, ideally perfused lung will have a VQ of 0.8. If they have a reduced ventilation, reduced perfusion, there will be dead space, there will be reduced ventilation, there will be shunt, they are the extreme. So normal to infinity. when there is an increase in ventilation and reduction in perfusion, higher ventilation, low perfusion, your VQ will be high. Where there will be reduced ventilation and increase in perfusion, your VQ will be low. So the other way around, V over Q. And V is high, your VQ will be high. When your Q is higher, your VQ will be lower. So this is how we go. Okay. So what is the VQ mismatch we are talking about? We are talking in between these two. We are not talking about 0 or infinity. The VQ mismatch we are interested is what is in between. Okay. From maybe from 0.1 to 0.9. Okay. The ideal is 1. Okay. Whatever less than 1, more than 0.1, like that, what we are talking about. So just have a look at it. First, look at the normal alveoli here. Okay. Normal alveoli will have a PaO2 of 100 millimeter mercury and PCO2 of 40 millimeter mercury after equilibration. So the blood that leaving the pulmonary circulation via pulmonary vein will have this. Okay, with the drop of a little bit drop of PaO2 later on. So this is, we are only talking about alveoli and pulmonary capillary. This is in the pulmonary capillary. This is what will be. In a patient with, so this is ideal. So talk about ideal. This is ideal condition, 140. VQ will be 100%. VQ is ideal. Okay. But in a patient with absolute dead space, as I mentioned, the PaO2 will be 100. Since there is no ventilation, there is no gas in the PaO2 150 millimeter mercury, because this is the total inspired air that come into alveoli without any dilution from the CO2. Because of alveolar gas equation, the partial pressure of alveolar oxygen drop because of the PaCO2 divided by respiratory quotient. So that component is not there. The PaO2 will be 100 millimeter mercury. So this is this in this graph if you look at it. Okay. So if you look at an absolute shunt, it will be the other way around. So the VQ mismatch will be high here and VQ mismatch will be low over here. Okay. So high VQ mismatch, low VQ mismatch. So if there is absolute shunt, there will be low VQ. Shunt causes reduction in VQ. Dead space causes increase in VQ. But both will lead to VQ mismatch. So that brings us to this, what we call as a O2-CO2 diagram. O2-CO2 diagram all talk about your oxygen content and your PCO2 content in alveoli in different condition for VQ. In ideal alveoli, you will get here at the PO2 100 millimeter mercury, you get a PCO2 of 40 millimeter mercury. You have to know this simple graph and these few values. If they ask you to do a O2-CO2 diagram, you have to plot a value of 50 under 50 at PO2 and the PCO2 of 0 to 50. So 100, 40, that is your ideal. Okay. In an alveolar dead space, there is no PCO2. You totally get the PiO2. Inspired PiO2 will be your PaO2. It's 150. Whereas in shunt, there will be zero ventilation. So PO2, PCO2 will equate the mixed venous blood, which is PO2. If you take a VBG, you'll get a PO2 around 40 or PCO2 of 45 millimeter mercury in mixed venous blood. So that will be this value here. At base, what this will get, because at base, there will be an inequality in your perfusion and ventilation. So that brings us to the regional ventilation and perfusion differences in your lung. This we talked about in absolute condition of shunt and alveolar dead space in a LT lung, in a patient who are, let's say, in a supine lung like that. But in a patient who are erect, apex to base, there will be a differences in your ventilation and perfusion. From apex to base, there will be decreasing VQ ratio. Means at apex, your VQ ratio is high. At your base, your VQ ratio is low. From 3.3 to 0.63. You have to know this value. Okay. Why is it so? Because there is differences in ventilation and perfusion at different regions of the lung. If you look at it, your ventilation at apex is 0.24 liter per minute, whereas your perfusion is only 0.07 liter per minute, because in an erect position, because of gravitational force, there is less perfusion to the apex. Whereas in your base, you can see The ventilation is improved as well, increased as well, 0.24 to 0.82. But the perfusion has increased tremendously from 0.07 to 1.29. Thus, it causes reduction in VQ. So there is inequality in regional perfusion and ventilation in lung. The both increase in ventilation and perfusion from the apex to the base, but the differences in increase is very much significant in perfusion compared to the ventilation, thus leading to different VQ at different aspects of the lung. Okay, that brings us to why there is a different regional perfusion. So we bring us to the west lung zone. The regional blood flow based on your west lung zones. I'm not going to go in detail about this alveolar, arterial, venous pressure. It's all based on our fluid dynamic classes before this. Your blood flow or gas flow, everything is from high partial pressure to low partial pressure. Okay. So we have a west lung zones of zone 1, zone 2 and zone 3. In zone 1, the alveoli are easily expandable. There's not much compression. They are highly expanded. Thus, the partial pressure alveoli is higher compared to arterial and venous. Thus, the pulmonary capillaries are compressed. The distended alveoli compresses the pulmonary capillary, thus reduce perfusion. Middle zone is almost everything is equal. So that's why VQ of 1. But at lower, at base, the alveoli are collapsed because of the weight of the lungs. Your alveoli are collapsed because of the gravitation. Thus, your partial pressure of alveoli is much lesser compared to your pulmonary artery. Pulmonary artery is bringing the blood from the right side of the heart. So, when the alveoli pressure is lower, the blood can easily flow into base compared to the apex. That's what the causes differences in the blood flow in the lungs according to west lung zones. Next, we talk about regional gas exchange. So when we equate this perfusion to ventilation, this goes back to these values in the graph form. You have to know this graph. So this graph can be asked in two ways, either apex to base or not dependent to non-dependent. In this picture, just pay attention to dependent to non-dependent. We will talk about apex to base in the counting of rib number in a short while. In a patient dependent to non-dependent, let's say the patient is lying on a left lateral position. So the dependent part will be your left side, your right side will be non-dependent. Okay, we can see that your ventilation and perfusion, your ventilation is more, of course, from the non-dependent to dependent part, it increases. But the increase of ventilation is not as significant as increase in your perfusion. The dependent part or the lower part, in an erect position, the base, the lower part, whichever is lower than the heart. The area that is lower to the heart will get increase in perfusion much more compared to the area that is above the heart, to put in simple form. In an erect position, apex is above the heart, thus they get less increase in perfusion compared to base. In a dependent patient who are lying in a lateral side, the part that on the floor, on eating the table, that the dependent part are lower than the heart, so that the increase in perfusion and ventilation is higher compared to the non-dependent part. And your VQ mismatch will always goes from the higher will be on the non-dependent part and lower will be in the dependent part, because your V over Q is based on your how much is the ventilation. Wherever the ventilation is higher, the VQ will be higher. Same goes to this. If you talk about bottom and top, in a patient who are erect, this is the rib number, top to below. You will label it in a reverse manner. You can see the part at the apex. It means the apex of the lung at the top of the rib number 1 or 2. Your perfusion and ventilation is low. As the goes down, bottom of your lung at the lower ribs, your ventilation and perfusion increases, but perfusion increases tremendously compared to your ventilation. Thus, there will be a regional VQ differences. So you have to know this graph, this graph O2 CO2 diagram and these values for ideal alveolus, alveolar dead space and shunt. So base will be somewhere here. Okay, if you put in this value, this value in this graph will be around here. This is the base. And then we want to know why there is a differences in regional VQ ratio. It's because of the differences in regional perfusion versus ventilation. Perfusion related to your west lung zones and your ventilation related to your apex to bottom because of the distension of the alveoli, which is easier to distend, and it's all based on the gravitational effect and the compression of the pulmonary capillary, and easier for the alveoli to distend and collapse. So this is the full way of putting it in one picture. So this is your apex and base. So you can say the ventilation improves from apex to base, but your perfusion improves even more higher. Thus the VQ response is different. So if you can look at it, the PO2, the PCO2, since alveoli at the apex are ventilated much better, there will be a washout of CO2 better compared to apex. So the PCO2 at apex will be low and PCO2 at the base will be higher compared to the oxygen as well, because ventilation is better at the better at your apex. Of course your PO2 will be higher because alveoli are much more ventilated. So thus when there is a PCO2 low, your pH at apex will be alkalotic, pH will be, your base will be a bit more acidotic. All these can come out in your MCQ. Based on your VQ relationship, the pH of the blood taken at the apex pulmonary circulation will be more acidotic compared to base. So that is wrong. Apex will be more alkalotic. So this is a overall picture to understand all these things. When you do MCQ, you have to relate to all this to understand. They can ask mix and match about all these things. So coming to summary, it all goes back to same things. Hypoxemia, there are 5 different causes. Low FiO2 is very easy. Most commonly in a physiological, it happens in high altitude. Otherwise, your FiO2 is same everywhere else. Even at high altitude, your FiO2 is the same, but partial pressure for inspired oxygen drop because drop in barometric pressure. Thus, it causes reduce in inspired oxygen content. Okay, that can cause hypoxemia. Then you get hypoventilation. Of course, you breathe normal, less gas exchange. Of course, your PaO2 will be low, but since hypoventilating, your PCO2 will retain, your CO2 will retain and increasing your PCO2. That's how we find out in a normal A gradient what is the problem within these two. Then we do A gradient, we get increase, and increase A gradient can be VQ mismatch, diffusion impairment and shunt, which does not respond to 100% oxygen is shunt. Why 100% oxygen does not respond to shunt? I a bit missed out here. Let me talk about it again. We go to this picture. Okay, in a sorry, not this. Let me look at the what is. Okay, we talk about alveoli that are being partially ventilated. We just focus on these and these two. Okay, these alveoli, let's say a person have a VQ mismatch or diffusion impairment. Okay, this is, let's take this alveoli as diffusion impairment and or VQ mismatch, either one of the problem. So when you give 100% oxygen, this PiO2 of 150, partial pressure inspired oxygen 150 millimeter mercury is when you're breathing room air at FiO2 of 21%. When you give 100% oxygen, this PiO2 of course will tremendously increase. Thus, your PaO2 alveolar oxygen will increase. Thus, your partial pressure arterial oxygen will increase. So both diffusion impairment and VQ mismatch will respond to 100% oxygen. Because even though there is diffusion impairment, when it increases your partial pressure of oxygen higher, the diffusion gradient will be higher and more oxygen will transfer through from alveoli to pulmonary capillary, thus increasing your partial pressure alveolar arterial oxygen. But in pure shunt, when the patient have a pure shunt, even though you give 100% oxygen here, only these alveoli are increased partial pressure oxygen, whereas this shunt does not come into contact. A pure anatomical shunt does not come into contact with any alveoli. Thus, increase in 100% oxygen will not increases this oxygen content in this flow. Thus, the improvement in PaO2 won't be much because this mixed venous blood will still dilute and reduce the PaO2 content. That is why response to 100% oxygen in shunt is not significant compared to VQ and diffusion impairment. Okay, in hypoxemia. Okay, so shunt can be large, does not correct. If there is a mild shunt, is it like a pulmonary shunt as I meant, less ventilated alveoli, your 100% oxygen might show some improvement. Then we have VQ mismatch and diffusion impairment. VQ mismatch is the most common causes. All these causes can be here. Diffusion impairment, how do we differentiate between these two? We do a diffusion lung capacity or diffusion capacity for lung of carbon monoxide, DLCO, come into picture. Okay, that is about shunt and VQ mismatch.